Blume edit. The Blume edit. The Blume edit. The Blume edit. The Blume edit.
You're listening to The Blume Edit, where we talk all things beauty, business, and being unfiltered. I'm your host, Kia, from Blume Aesthetics. Welcome back to The Blume Edit. I'm Kia from Blume Aesthetics, and today I'm joined by someone who's made a major impact in the medical world. Dr Vij Vijayasekaran is a specialist plastic and reconstructive surgeon with over 25 years of experience, international training, and a career spanning craniofacial, hand and microsurgery. He was also one of the first medical responders during the 2002 Bali Bombings, a moment that deeply shaped his path in healthcare. Dr Vij, thank you for being here.
Thanks, Kia. Thanks for having me on your show.
Thanks for taking time out of your busy schedule. You were saying to me earlier you get 2 Mondays off a month.
Yep.
So this is probably family time I'm cutting into and all that sort of stuff. But you just got back from holidays.
Yep.
Do you get much time to take off and go on holidays?
We tend to take regular school holidays off
Yeah.
with the kids and the family. So
Nice.
Yeah,
Went over to New Zealand.
yeah, exactly.
My hometown.
Exactly.
Beautiful. Well, let's start from the beginning. What led you into medicine and what made you choose a path in plastic and reconstructive surgery?
There are several factors that led me into medicine. We have some medical background in our family. My grandfather was a doctor in Sri Lanka, and a lot of my mum and dad's siblings are in the medical field. So that was a bit of a background into medicine. I guess probably the two things that led me into medicine at 17, when we went through, you had to make a decision early. And at 17, as you know, it's very hard to know exactly what you want to do in life. I guess I followed my brother in whatever he did. So my brother's a couple of years older than me. He's an ENT surgeon, and he did medicine, so it was kind of what I was just going to do, did what he did. And I guess took my dad's advice. My dad was an accountant and moved to Australia in 1984. So we came here. He was probably in his early 40s. And he, from being his own boss and being very, head of big company in Sri Lanka, he had to start again. And his advice to us was be your own boss. And in medicine is one of the areas where you can be your own boss at a very early stage and you have more control of your destiny. And I guess in the 80s, Australia was a very different place. There was less diversity. For us, it was a clear way of being in control of our destiny. And so I guess that was probably the couple of reasons why I did medicine. As for plastic surgery, I got to a stage when my brother did ENT. I went, there's no way I'm doing that. And I chose plastic surgery mainly because it's probably the most diverse surgical specialty. So for those who don't know, it's not just about cosmetic surgery. It's about reconstructive surgery, cancer surgery, and cosmetic surgery. So every operation is pretty different. We operate on different parts of the body. It is also a very operative specialty. So I like things moving fast, and those who know me know that I like the pace of things moving. And it was one of those areas where your operating lists are different. You also have a lot of variety, and it's very surgical. And I like being in the operating theatre. That's I guess the reasons why I chose plastic surgery.
So you mentioned your brother, Xian. So
Yep.
I've worked with both of you guys. So Xian and you're both very different. Would you do you think you're quite different?
We're
same but different.
We are same but different.
And he's older.
He's older. He's a couple
Okay.
of years older, though
Yeah.
he acts younger than I do. I am probably the more conservative
Yes.
of the two of us, but we are very similar in a lot of ways, in the way we think, in the way we do things. But yeah, he's more extroverted than I am.
He's more extroverted. You both have good work ethics. You obviously got that from your parents. Good work ethic, hard workers, attention to detail.
Yeah, look, I guess we watched our parents, my dad and my mum, both work hard, and and I guess that's what we sort of took from them.
Sometimes if I'm talking to clients or other people about both of you, I use the work Christmas party as an example in terms of Vij probably wouldn't come to the Christmas party and Xian is on the dance floor at the Christmas party.
Yeah.
That's probably the best way to explain the difference.
Look, I like deep connections, so I find some of the Christmas parties you can't really speak to anyone. My wife loves to dance, and Priya as well. So I usually come to the PCH Christmas party because I come with her, and also because I work there. But yeah, you're right.
Yeah. All right, well, let's get down to business. Tummy tucks and breast augmentations are probably two of the most commonly talked about surgeries at the moment. There's often a gap between perception and reality for patients, I think anyway. In your experience, what are some of the biggest misconceptions that people have about these two surgeries?
So I guess with breast augmentation, it's not a one-size-fits-all operation, and unfortunately, patients look on websites and on different forums, and they see a post-op result. But a post-op result is primarily driven by your pre-op appearance, right? And so your pre-op breast aesthetics does determine what operation you need, what result you're going to get, and it's not just about CCs. It's about your breast, the base diameter, how much ptosis you have, your skin quality, your age. It's multifactorial, and I guess that's probably the disconnect in the breast augmentation space, is that you can't just look at a post-op result and say, I want that size and that shape, because you really need to look at closely the pre-op shape, size, etc. So that's probably the misconception with breast augmentation, and I'm happy to discuss later, but that's been fed by the various social media and websites that have exploded over the last 20 years. With abdominoplasty, probably, again, someone looks at a post-op result and thinks that's what I'm going to look like post-op, but they haven't looked at the pre-op. And again, your BMI, how much loose skin you have, how much muscle separation you have, all determines your post-op results. So if your BMI is high, you're not going to get a result of someone who's got a low BMI, who's just got muscle separation and has had an abdominoplasty for that. So again, I always tell my patients, you need to understand your pre-op position, your pre-op aesthetics and your pre-op anatomy before you can understand your post-op results. And it's about getting that, as a surgeon, I guess it's about getting the match between perception and expectation and reality, I guess, getting your patient to understand those three factors.
Do you ever have people or patients after surgery come to you and say, this isn't what I expected?
Yeah, so obviously it's just human nature sometimes to not hear everything in the consultation, and that's why we have a couple of consultations. And it's really about us trying to communicate that to the patient. So you do get patients who have a mismatch between expectations and reality. And I guess as a surgeon, that is one of the primary things, is to try and get everyone on the same page.
Yeah. With the tummy tucks, what typically causes the kind of abdominal muscle separation that you were saying, or that skin laxity? Like, what is it that causes the two different? Because is it they can have the muscle separation and the skin laxity, or is it separate?
Yeah, so you can have combination. So I guess you could put it into skin laxity, adiposity, so the thickness of your abdominal skin fat layer, and your muscle separation. So I guess you could put into those three. So muscle separation typically comes from pregnancy. So pregnancy results in separation of the muscles, so you get divarication of the rectus muscles. Most abdominoplasties, we do repair the muscles, because most patients who come for an abdominoplasty typically have had kids. If you've got a wide separation, you can do Pilates till the cows come home, and you might strengthen those muscles, but it's not going to necessarily fix the divarication. And so the divarication is surgically fixed by bringing those muscles together. And the benefits there are, if you have back pain, etc., it can be improved with that, and the overall contour of the abdomen can be improved by that. So that's, I guess, the muscle separation part. The loose skin, probably the patients that we see, one in the pregnancy, patients who have got a lot of stretched skin as part of the pregnancy, as well as the weight loss patients. So they're probably the two categories of patients that we see. So typically someone who's had multiple pregnancies or large pregnancies will have a combination of muscle separation and loose skin. And so they probably get the most benefit, particularly if they are in a normal BMI range from an abdominoplasty, and they get probably the best results. The weight loss patients have significant skin laxity, and there's only so much you can tighten the skin without, or excise the skin without killing the skin, right? And so it's that fine balance between tension, a reduced blood supply, and the elasticity of the skin. So they've lost elasticity, so you can tighten it, but when the skin relaxes post-surgery, there still can be a bit of redundancy. And I guess the third patient is the patients who have a slightly higher BMI. And they're probably the patients that get, of all those categories, probably the least aesthetic result, because the thickness of the adiposity can't be thinned with liposuction at the time of the abdominoplasty safely. So typically I tell my patients the lighter you are, or the closer to or below the BMI you are, the better results you're going to get from an aesthetic point of view.
I had a consult with you once. It was probably before any surgeries you've done for me, so because you've done a few surgeries for me. And the first question that I asked you was, can we do liposuction on my ankles and calves? And do you remember what you said?
Yep.
No.
No. Yeah.
I have always felt like I've got, I guess you could say, cankles or like fat around my ankles or calves, right? And so I went to you and I said, I'm turning 30. I want liposuction there. And you said no because of the risks. So there's risks. Is it because it's quite a tight, small area? Is that? Yeah,
look, it's multifactorial. It's a tight, small area. Liposuction is not the be-all and end-all that it's made out to be. Your skin needs to take up, but also it's a blood supply issue. Complications from liposuction below the knee are high, and that's why we rarely do it below the knee.
So then I moved on. So I was like, I think you said you just need to go to the gym. And then I moved on and I said, what about my arms? I said, can we do liposuction in my arms? And do you remember what you said for that?
I probably said that you'll end up with loose skin.
Yeah.
Yeah.
And you said you'll have scars.
Yep.
So you said you said you'd have loose skin and then would need a cut.
Yeah.
And then you'd have scars. So I said no to that. So I think I also asked you, is this something that anyone else in Perth would ever offer? And you said you could find someone that would do this for you, but I'm not doing this for you. So we ended up going and doing liposuction of my legs instead, my thighs instead. But it's just interesting to have that approach where you get told no. Like I don't think I was expecting that. Like I didn't realise that there were such risks with the ankles and the calf. I just thought you would say, yeah, let's book it in. So I found, and then even with the arms, you were like, there's no, like, you're 30, there's no point in getting liposuction and then having these big scars when they're not that bad. I think you said go to the gym again as well. And so I've done nothing for them. But yeah, it's just interesting from my point of view and probably the listener's point of view in that people do say no, like surgeons do say no for safety reasons and aesthetic reasons.
100%. Look, I think I always tell my patients when I say no, it's easier for me to say yes than to say no to a patient because, they've waited for the consult, they've come in and they expect that they're going to get a surgery out of the consult. But ultimately, we've got to do what's right for each patient, and each patient is different. We say no as plastic surgeons because we don't think it's the right operation or it's a safe operation or you're the right candidate, and ultimately that is really the foundation of delivering good patient care, right? It's just doing the right thing by the patient.
What's safe and
100%.
Absolutely. Going back to the abdominoplasty, the tummy tuck, what's actually involved? You said there's the muscle separation, so you're obviously having to put the muscles back together. When it is the muscles and the skin, what's actually involved in that procedure? Obviously,
we start off with a low incision. Usually it's at the level of, most patients have had a cesarean who have come to see us, or if they haven't, it's a low incision, goes from hip to hip. And obviously there are different types of abdominoplasty. This is the standard abdominoplasty with plication of the sheath. Obviously there are mini abdominoplasties and fleur-de-lis abdominoplasties, or the circumferential. So there are different types of abdominoplasties, but typically the standard abdominoplasty, a low incision, we raise up the skin flaps, so we cut around the belly button. The belly button stays on a stalk, so the umbilicus is on a stalk. We raise up and then we tunnel up through the midsection, and then we tighten the muscles, and then we resect what can be resected safely. So it's a balance between tension, limited blood supply. So the two things that cause wound complications are, obviously too much tension on the wound, a reduced blood supply, and then other factors like, smoking, etc., infection. So it's getting that fine balance, right? So there's a limit on how much you can resect. And then we obviously, once we've repaired the muscle, resect what skin we can, we bring the belly button out through a new hole, and then we close the layer in layers. So that's essentially what it involves.
So you said circumferential, so you sometimes do the entire...
So typically for the weight loss patients, we do a circumferential. abdominoplasty.
How do you find the wound recovery for that? Because there'd be a lot of pressure on.
Yeah, so it's a bigger operation. It's typically a weight loss patient.
So with all the weight loss drugs sort of trending at the moment, are you finding you're getting a lot more patients come through with the abdominoplasty requests?
Look, at this stage, we probably haven't seen a significant change because a lot of those patients who are on the weight loss drugs previously were probably having bariatric surgery. So I think total number of patients is probably the same. It's just that the way they're getting their weight loss is different.
So there's probably less bariatric surgeries happening then, which
there's
is
definitely
amazing.
There's less bariatric surgery. If you speak to the bariatric surgeons, there've been an increased number of bariatric surgeons over the last 10 years. In combination with the drugs, the patients that were probably at the lower end of the weight range that were having bariatric surgery are probably not having bariatric surgery, and they're getting their weight loss with the medications. So
pretty good compromise, I think, having medications instead of surgery. It's pretty good, hey? Is there any particular cases or patient stories of yours that stayed with you, either for the challenge, for the outcome, something memorable?
The child with a cleft lip in Africa. So we, on one of the surgical missions, the child was 9, was not brought into public because she had a cleft lip, and because of that she was malnourished. And 9-year-old in Australia, there's nowhere 9-year-old in Australia would go without a cleft lip operation. And so after the cleft lip operation, the family were happy to bring the child out into public. Sort of shows what plastic surgeons do and the extremes of what we do and the difference you can make as a plastic surgeon.
You probably underestimate some of the things you actually do in the private and the public system, but I think working like alongside you and other plastic surgeons, some of the surgeries that I even did where you guys would be like, yeah, this is normal. Speaking of amazing things, you and Priya were in Bali at the time of the 2002 bombings and became one of the first medical responders on the scene. What do you remember most vividly about those first few hours?
Priya was coming up for her final exam. So Priya was an anaesthetic trainee and I was a plastics trainee. And so it was a holiday before she started studying. So we arrived there Saturday morning. The bomb went off Saturday night. And then we got to the hospital Sunday morning after my parents ran. We weren't aware that there'd been a bombing. We just knew that something had happened because we saw the explosion in the distance, but we couldn't get any information that night. So we arrived early at about 8 o'clock on the Sunday morning. And I was, Sangla Hospital was one of those developing nation hospitals, single or 2-story, but sprawling, long corridors. And I guess when we first got there, it was probably a lot of the patients had been moved to the different wards, and it was probably it was quiet, despite because there were no other volunteers there at that stage, or not many, and there was just the local staff, and the patients were obviously just shocked of what had happened to them. And then from there we rapidly started treating these patients. And I guess the most striking thing that was just the lack of resources, right? And the number of critically injured patients. I think it was the most number of patients at that stage from a mass casualty situation, because in the previous incident was the 9/11, and there weren't as many patients that got to hospital. Most died. So there were a lot of critically injured patients, and I guess it was that the lack of resources that we had to deal with to operate on these patients and to manage these patients from a critical care point of view.
I've watched the movie. I'm not sure how accurate that was, but I watched it when it first came out.
For the accuracy, it's pretty accurate to an extent.
Yeah.
When I came back from Bali, one of the Royal Perth secretaries, Lisa, said to me, you need to write this down because one day someone will ask you. So I got a dictaphone and I just verbatim put down the 24 hours, what happened, and she typed it out for me, and my parents had a copy of this. So when they contacted us to make the movie, I just said, why don't you read this? So the script for that first bit is relatively accurate. So Priya sort of looked after the really critically ill patients with resuscitation, because she was an anaesthetic training, and they typically look after critically ill patients. And I did a lot of the escharotomies in the early stages. So that's releasing the the tourniquet effect of the burns. And we were sort of then went on to really coordinate the aeromedical evacuation of who's going first, etc. So yeah, it was a combination of the early management of patients needing urgent care, because we didn't have an operating theatre to take people to. So literally I had a box of blades and a box of gloves, and I went for 100%. And with no analgesia, no anaesthetic. And Apriya's role was really looking after the really critically ill patients, resuscitating them.
Was there airway burns? Quite a few airway burns?
There were some airway burns.
Yeah.
There were a couple of patients in an ICU that were already in the ICU, but she couldn't intubate anyone because she didn't have the equipment. There was no equipment. She had a cylinder of oxygen that she had to share between patients. That's how resource strapped they were.
So that kind of moment, being chaotic and traumatic and really obviously quite urgent, that sort of changes people and changes your story, right? How did it shape your approach to medicine, leadership and your life?
I think one of the things for us, because we were together, we could get on and deal with the aftermath of it, right? And it was also what we did every day. We found it a lot easier to deal with it from an emotional point of view. Like, we didn't get any counsel. We saw a counsellor because we were made to once, and they said, you don't need to come back. You guys are good. So how it's shaped me in medicine, look, it's probably from a leadership point of view, one thing we had to do to lead that evacuation was to bring everyone along, right? Because even though we were probably the youngest of the volunteers there, we had the right skill set. It's what we did every day. And so we had to lead with humility, right? And we had to bring the local staff along too, because there were a couple of people that were turned away from helping, probably because they were older Caucasian men. We were young doctors of colour. It was easier for us to get into that situation. That was the reality. And then we had to lead this team of volunteers to change things. So I guess that humble leadership, bringing everyone along in your team, respecting everyone's role in this effort to help people. And I guess it from shaping how we it has changed us from a career, probably taught us to be a bit more nimble and improvise and less fussy in the operating theatre and managing with what we have, and not saying I can't go on without this piece of equipment. So it taught us to be very flexible.
And a lot of good, I guess, came out of a pretty bad situation. So like you said, obviously the things that you learned about yourself and built. Also, when you got back to Perth with the patients, you were met by people like Fiona Woods, who then later went on to create things because, is that right? So the spray on skin, was that a result of her experience?
So spray on skin was in development. We were using it.
But it was heavily used.
It was heavily used. So it probably got, got popularised. It was used more widely, and
because you could see the results probably from all those burns victims.
Yeah, so it's an adjunct to everything else in burns.
Yeah, when I was working at the Children's Hospital, a colleague of mine there, she's obviously been around for a long time. She remembers the time of it happening, of everything happening, and she told me that back at PMH, they would have shuttle buses from PMH to Royal Perth, and they would take the nurses because they had to put a lot of the elective surgery here on hold. Is that right? To cater for the influx of resources required, equipment, people, things like that. And she would go over to Royal Perth to then help with all the influx of patients and surgeries. Yeah,
so it was an amazing time where everyone pulled together from, not just from the plastic surgery community, from the nursing staff and allied health, and it was a huge effort. And they put a lot of surgery on hold. So a lot of the burn surgeons from PCH did go across to Royal Perth to help. There weren't as many pediatric burns from the incident. There were a couple of kids that came to PCH, but most of them were adult burns, so they were managed at Royal Perth. And I think it was 2 or 3 weeks after the bombing, pretty much every day there were several plastics theatres running, which was unusual to have several plastics theatres running simultaneously, and surgeons from both private and other hospitals all came to help. So,
And unfortunately with things like burns, it's an ongoing sort of process. So it wouldn't just be one surgery. It could be several surgeries for one patient. So those resources, and it's changing of dressings every day, few days, things like that. So the resources are just continuous and exhausted, probably WA of
it was,
Australia, you know.
Yeah, it was definitely a time where a lot of the resources were put in, but the teams pulled together really well, and it was a really well coordinated effort throughout the country.
And has that experience for you changed the way that you show up now for your patients?
Look, I don't think it probably changed it significantly. You know, we went into medicine to help people. That's why we volunteered. You know, we saw we were needed, and we volunteered our services, and so it probably hasn't changed how we approach our patients. Probably has taught us to be more grateful for what we have, and particularly appreciative of how good our medical system is in Australia. You know, we have a great medical system, and when you see the resources and the facilities in other parts of the world, it makes you appreciate that even more.
And you do quite a few trips overseas for the
cleft lip and palate. So I guess I'm a cleft lip and palate surgeon. That's my public appointment, and that's what I do. So I do a few trips overseas.
Make a difference elsewhere as well.
Yeah.
So you've trained and mentored countless junior doctors and surgical teams. What do you believe makes a good surgeon beyond just their technical skill?
Yeah, so look, I think it's a combination of things. I think firstly, I'm a big believer in insight and humility, and probably resilience and hard work. So insight and humility. I think firstly as a surgeon, it's you lead a team better, you bring people along, and you often put at the front end of the team by everyone, but everyone makes a difference. Everyone's part of the team, and I think you get a better outcome for your patients and for yourself and for everyone who's working with you when you lead with humility. And insight, I think insight's a really important thing as a surgeon, or in medicine, is the ability to constantly want to check that your own self and your outcomes, and not just think that everything I do is great and I'm the best surgeon in town. And I think insightful surgeons are often, and insightful, humble surgeons are probably the best surgeons. And I go back to my mentor that probably made the biggest difference in my career was David Fisher, who's a cleft surgeon in Toronto, and he came up with his own surgical technique for cleft repairs that is now used worldwide. Probably the most popular repair, but when I trained, it was probably very early stages. And he would never beat his chest about his results, but we would go to these meetings with him, and all these great surgeons were presenting their results, and we'd be like, you need to come to Toronto and see David's results because they're just like so different. But he was not someone that would get up there and say, look at me. And he was constantly questioning what he did which makes you better. And then I guess the resilience and hard work. Well, I think I tell my trainees that, you train hard, you play easy, right? And surgery is about it's like an apprenticeship. It's a technical skill with the right judgment for the right patient, right? So it's about the more patients you see, the more patients you treat, and the more operations you do, the better you're going to be at the end. And so I tell them that, it's not about just ticking a box, I've done this operation, I've seen this case. It's really about the more of every case you see, because every case is slightly different, right? And I think that's what plastic surgery training is so good about. It gives you these skills from all aspects of surgery, from microsurgery through to macrosurgery, and you can put those skills into and principles into dealing with lots of different types of conditions, right? And I think that's what makes our specialty great. And so to the trainees, it's like, you go and do, 100 of one simple operation. When you finish, you're going to be better at doing that operation than if you just did two.
Yeah.
Because you would have seen all the variations and permutations and combinations that condition can present with, and you'll be able to manage that, right? And then the resilience is part of being a surgeon. You know,
being in the medical industry.
Yeah, look, and I guess it comes back to Bali. One of the things was when we were in the moment, we never thought, oh my God, this is too hard, or how hard, I can't deal with it.
Yeah, you couldn't do that.
When you're called to action, you just, in that moment, you have to do what you're trained to do, and you can think about it
Later.
after the moment. But when you're in that moment, you need to be resilient, and particularly surgery and, the higher end surgical specialties. If you've got a bleeder, you can't just
sit there and think about it for a minute.
Yeah, down tools and say, I can't deal with this. So, having that resilience, but that all comes with, training and skills and expertise. So.
Yeah. What's one thing about theatre or surgery that people would be surprised to hear?
Look, I think I love being in the operating theatre. I love being in the operating theatre with people that I know, right? Because then when you're working with the same team, everything works really well, right? We don't have a party in there, but the more relaxed you are in operating theatre, and when everyone knows what their role is, the better it is. So, it's a fun place to be at the operating theatre, for me anyway.
Do you like having music on?
Yeah, look, I don't play super loud music. I like background music. It just it's amazing how it just calms the atmosphere. Yeah. So we often have music. Usually the anaesthetist decides what the music is. Yeah.
It'll be a different genre walking into your theatre and then walking into an orthopaedics theatre or something. The orthopaedics is loud. It's gets them in the mood for cutting bones. For you, it's more like concentrate, fine, delicate vessels, things like that. But
yeah.
So medicine in general can be intense, emotionally, physically, mentally. What advice would you give to younger surgeons about longevity and balance in their career?
Making time for your life, right? I think it's easy. It's a very consuming, medicine's very consuming, especially as a surgeon, you can always work, and you just need to strike that balance that works for you. For me, being married to another specialist, we had to strike a very good balance because we both had careers, and so we prioritize our kids, and our life together. We prioritize that, and I think that's really important because you can work all the time, and then ultimately you burn out.
Yeah.
So I think it's just getting that right balance that works for each person, and everyone's different. Staying fit's really important. I think particularly. It's the hours are long, the work's intense, and the fitter you are, the easier it is to do your job, right? So I think I maintain regular exercise, and I guess it's probably something you don't realise when you're younger, but sleep's important too, and getting that balance right. But ultimately, it is consuming because you're on call all the time for your patients, but you just need to. So I made a very early on in my career, I found that I'd come home, I'd be still dictating when the kids' notes, patient letters, etc. So very early on, I put a limit on not bringing any work home.
Yeah.
So when I come home, I'm home. I don't do any notes or anything when I come home. Everything's done when I go. So I've sort of taught myself to be efficient in that process. Because if not, you're working all the time, and that's what I think burnout's a bad thing. So.
And then it has an impact on your patient care then, because you're not being
100%.
your best self.
Yeah.
So technology is changing fast at the moment. How have innovations like 3D planning, imaging, or even AI begun to shift how you approach surgery?
So look, 3D planning is something that I don't necessarily use at this stage for anything we do, but obviously the orthodontics are some of the other jaw surgery and stuff in plastics they do use, and some of the reconstructive for bony reconstructions, they do use 3D planning. I think AI and robotics is probably the frontier that's potentially coming our way faster than we realise. But I think AI will change a lot of the things we do to make it more efficient. For example, I don't use a typist. I use AI dictation. There's AI consultations where you just consult and the AI will just produce the letters, etc. So I think it'll make things efficient and it'll impact other areas of medicine first before it impacts surgery. For plastic surgery, I was thinking about this the other day. I was doing a bilateral cleft lip in like a 3-month-old. Tricky operation, small tissues, small incisions, and I can't see a robot doing that operation in my career, and possibly not in the first half of my kids' careers, but I think it'll come.
One day.
And there'll definitely be robotic assisted surgery, which there is now for, orthopedics and for urology and general surgery, but that cutting the skin is a tricky thing to do. And so, I think the robots will make things more precise. They'll still need a surgeon to do the operating, and I don't think in the next 20 years at least there's going to be a robot that's going to be doing the operation. But it'll come.
I don't think people realise how much assistance we already have in the operating theatre. For example, the navigation systems that are used to, say, for example, locate a brain tumour and to see, to assist them with dissecting that away and knowing exactly where to go. I think that's what's mainly used these days in terms of that assistance. But would there ever be a robot excising a tumour out of a brain?
Probably
not for a long time.
But look, I think in plastics, probably the one area I can sort of see is robotic assisted. Well, firstly, microsurgery will get easier because the microscopes are really advancing, and there'll probably be robotic assisted microsurgery. When we're repairing a 1 millimeter blood vessel and you need to put 10 sutures into that 1 millimeter blood vessel, that precision and stability and control will probably be able to be done with the robotic assisted techniques. I think those are some areas that I think it'll change, but it's not going to take over everything. It will eventually, but not in our lifetime.
So speaking of, time past, have you found that patients' expectations have evolved or changed in the last, say, 10, 20 years?
Yeah, I think in the last 20 years, 20, so I guess when I was training in, the early 2000s, there was no social media. There was internet, but you couldn't, you would never, a patient would never really see another person's outcome. So no one really knew what the range of outcomes are. And I think with the advent of social media and just the large consumption of information and the amount of information that's out there, it has changed patients' expectations. It's changed, I think also probably in some respects it can give patients a wrong idea about what to expect, because it's not just about looking at the post-op photo. You need to look at large number of patient outcomes, and you need to look at what their preoperative image was and compare that to yourself to find an outcome that's going to be for you.
Yeah. And is there an area within plastic or recon surgery that you think will be or will see the most progress in the next decade or so?
Look, I think in microsurgery we're getting, doing smaller and smaller blood vessels with less and less morbidity from a donor side point of view. I think that'll progress. From a cosmetic surgery point of view, I can't see anything changing rapidly. The techniques will still stay the same. There might be better prostheses, etc. Probably, but I can't see any rapid changes in the next few years.
And so, when you reflect on your career so far, from the operating theatre to the danger zones, what are you most proud of?
Look, I think I'm just most proud of being a plastic surgeon. So plastics is just an amazing specialty. We in Australia are really well trained. We've got really high standards. We train our trainees really well. And when we go on fellowships, people in other countries, if you're an Australian trained plastic surgeon, they want you to be in their fellowship program. It's really easy to get fellowships overseas. And so I guess I'm proud of that specialty because I'm biased, obviously, but I think it's the most diverse, and it's probably the specialty that we have skills that are from, like I said, from microsurgery to macrosurgery, and we can operate on lots of parts of the body, lots of different operations, which makes it unique, and I think it puts us at the front end of surgical specialty. So I guess I'm probably most proud of being a plastic surgeon.
And finally, if you could go back and speak to yourself as a young registrar, just starting out, what would you say?
That's a good question. You got me there. Look, I guess probably keep doing what I did. We probably could have. I know I've had a great career. I've enjoyed what I've done. It's hard to say what I would have done differently.
Sleep then, because you probably won't sleep later.
Yeah,
possibly
sleep more. We've like I said, we've worked really hard on getting that balance of family and career right, and got 3 girls, and we spend a lot of our spare time with them. So we made that choice early. It was a decision between, being like working in a city like Toronto or Melbourne, where they're big centres, or coming back to Perth. And we probably made that decision for our kids more than anything else, and as a couple, and we have had a good family life. So yeah, so I can't really think of much I could change.
Oh, amazing. That's good. Good reflection, I guess, isn't
Yeah.
it? Well, Dr. Vij, thank you for sharing not just your knowledge, but your heart and humanity today. Your career is an incredible example of what it means to lead with both precision and compassion. And I'm so grateful we could bring this conversation to our listeners. To everyone tuning in, I hope this episode gave you a greater appreciation for the people behind the profession and the depth of care that exists beyond what we often see on the surface. Until next time on the Blume Edit. This is the Blume Edit, unfiltered, unscripted and unapologetic. Subscribe now and tune in weekly.